This is a very old cataract. The patient says that this cataract has been there for the last 10 years. Whole of the anterior capsule is fibrous except for some portion in the lower side. So I was hoping that I will get a cleavage, and many a time if you get a cleavage you can do a good capsular access. So I was trying to find out the cleavage, but I was not successful. You may notice that I am doing the rhexis under irrigation cannula. So that is the procedure what I follow here. I am again trying to find out the cleavage, but I don't see any. So I changed my strategy. I know that I cannot cut this capsule with scissor, so I took help of the Phaco probe. At sculpting mode, 80% vacuum, I started cutting the anterior capsule, fibrous anterior capsule with the Phaco probe, and to my surprise, I was successful in removing the central portion of the anterior capsule in a very controlled way, as if I am doing a capsular access with a Phaco probe. So my intention was to create a space inside and do the Phaco, and as one notices, I was able to achieve this good amount of exposure of the cataract. And once I have done it, now I started doing sculpting. This is a Centurion Phaco using the balance tip. So sculpting is easy. I am using 80% Ozil power. So first I am making a crater in the middle of the cataract. This is my technique in cases of very hard cataract. This way I can debulk lot of tissue inside the bag. One may notice the capsule is coming, and I am putting the chopper to prevent it from coming, and I did my far chop, and I was pretty successful. There is a technique what we call step-by-step chopping with lateral separation. Once we make a crack, we reposition the chopper at different depths. So rotation was done, and now I am trying to do the second chopping. Again I am holding at 600 vacuum. I'm not doing now. I will hold it at 600 vacuum, and I will try to make a chop here. Again the same chopping technique, step by step chopping with lateral separation. I will hold here firmly. No, not it. I mean, it's rotating. So I'm waiting it to get steady and to find a good area where I can do chopping. So in the meantime, I decided to put viscoat. So this is a free patient. So I thought if I can put viscoat, the corneal endothelium will be better protected. So this is what we put viscoat now. And again I will try chopping, quite difficult chopping, but is not impossible. So here again I hold it at 600 vacuum and trying to do the chop, step by step chopping with lateral separation. There is a reposition the chopper at the depth and laterally separate at the same time. This is a technique developed by Dr. Vasavada. You can find it in the JCRS old journal. Another chopping, step by step chopping with lateral separation. So here I place the right hand steady, and with the left hand I do all the maneuvering. So I was pretty successful in separating these fragments. And now it is time to take them out. I try to do is it as endocapsular Phaco as possible. So it is not apparent in the flat screen of the TV monitor, but in fact I was doing it in the bag itself, so no major harm is inflicted on the endothelium. Now I have brought down the vacuum 400, 600 is not needed now, and slowly inside the bag I am taking out the fragments. The bag is pretty stable now, and it looks like as if I am doing on a usual capsular axis eye. So I have just, in the last piece, I brought down the vacuum to 400, and now I am doing very slowly so that I am more careful to the endothelium. So I have completed it, and one expects that there is no cortex here, so I went ahead with the IOL insertion. That also I do underwater, I mean irrigation fluid. So here I am putting the lens into the bag. The bag is acting very strong, no problem. The lens was not inside the bag. I maneuvered with the aspiration cannula to be inside the bag, and I am pretty much, the lens is inside the bag, and I decided to keep all these things, white things around, because if I try to remove it, it will compromise with the integrity of the capsular axis. And thank you very much.